Good afternoon, everyone. This is Christine Friedenreich speaking. You have joined us for the Anatomy of a Pandemic, Policy Implications of COVID-19. This is part of a series that is being run by the O'Brien Institute for Public Health at the Cummings School of Medicine, University of Calgary. Before we begin, I would like to take this opportunity to acknowledge the traditional territories of the people of Treaty 7 in Southern Alberta. The city of Calgary is also home to the Métis Nation of Alberta, Region 3. This series, which we're calling The Anatomy of a Pandemic, digital form, showcases the work of the O'Brien Institute members and the wider University of Calgary community, and what we are doing to support authorities and governments in their response to the unprecedented scale of and human cost exacted by the COVID-19 outbreak. I'm moderating this series. I'm the interim scientific director of the O'Brien Institute for Public Health. This webinar and past webinars are being recorded and can be found on our O'Brien Institute website, which is given here on the slide. I'm very happy today to be able to introduce our two speakers, both from the School of Public Policy. The first speaker will be Dr. Myles Leslie. He's the Associate Director of Research at the School of Public Policy and also an Assistant Professor in the Cummings School of Medicine, Department of Community Health Sciences. He's an ethnographer, and his health services research focuses on how policies are or are not implemented on the front lines of primary and acute care. He holds a CIHR COVID-19 Rapid Response Operating Grant and has been studying the channels of communication and policy implementation in Alberta's response since early March. Our second speaker is Dr. Jennifer Zwicker. She's the Director of Health Policy at the School of Public Policy and also an Assistant Professor in the Faculty of Kinesiology at the University of Calgary, and is the Deputy Scientific Officer for Kids Brain Health Network. She has broad interests in the impact of health and social policy on health outcomes. Dr. Zwicker's research program assesses interventions and informs policy around allocation of funding, services, and supports for youth with disabilities and their families. Today, you will be able to ask questions of our speakers, and there are three different ways that you can ask these questions: using the question and answer box in Zoom. You can also use the comment box for those who are joining us with Facebook Live, or you can also send us your questions through Twitter at O'Brien COVID-19. Now I'll hand it over to our first speaker, Dr. Myles Leslie.
Afternoon, Christine, everyone. Thank you so much for joining us. This is what you get, me in my basement. After this, I just turn into a deck of slides. Thanks so much for being here. And of course, the usual technical, I'm not entirely sure whether I'm pressing the correct buttons. Hopefully you're all seeing the first slide. A little bit more about the title in a moment: Experimental Surgery in a Response, given that there's almost no surgery going on, let alone experimental. Odd, trying to hook you in. And I will now move forward with this. There we go. Really excited to be part of this installment of the Anatomy of a Pandemic series. My speech writing guide tells me that the best thing to do is either begin with a joke or with some controversy. I'm going to opt for the second of these this afternoon. It's an interesting title for this webinar series, I would suggest. Maybe I'm going to manufacture this, but controversial even. One I think we might want to revisit, at least in the context of the research that I'd like to talk to you about. How so? Well, I think we all have a sense for what anatomy is. It's a subject you study. You go to an exam at the end of the course and you're asked to identify a particular part of a human that you might be looking at. It's all about bones and muscles and organs and tissues and how they all fit together. That all works. It's quite a nice metaphor for the webinar series. In each talk in the series, you're going to have a chance to look close up at some particular bones and muscles. The controversial bit is that anatomy is usually a subject where the living learn by looking at the dead. The idea of doing an anatomy has been with us for quite a while. Back when it got going, it was done in theaters. So a bit like today, a bit of a performance. And it all sort of boiled down to a live streamed butcher show. The live part was confined to the anatomist. The body was just the body. Its job was to be dead and to give up its anatomical secrets. There is, of course, a version of anatomy where both the anatomist and the body are alive, but that is something that ethics boards and people with any sort of moral center at all tend to frown upon. It is, to say the very least, controversial. And so the study of living anatomy, of vivisection, is in and of itself controversial. And from that point of view, what we're doing here today is controversial indeed. The good news is that neither this webinar series nor the research I'd like to talk to you about are in fact interested in carrying out vivisection. Rather, they share the goal of looking in real time at an evolving phenomenon. In this case, and in this sense, they aren't really so much interested in an anatomical study of the dead, but a surgical intervention on a living set of policy muscles and service delivery bones. Now, I pick surgery here partly because anatomy theaters gave way to operating theaters. The anatomical secrets of the dead became the surgical secrets of the living. But the performative, educative aspect has remained. It may be a performance of sorts, but surgeons do not go into their theaters as vivisectionists to test. Rather, they go in with a mission to intervene, to correct muscle, to improve bone structure. And so, I'd like to propose, having made my controversial opening per the speech writing guidelines, that for at least this talk, we retitle the series. We switch it from an anatomy to experimental surgery of a pandemic. It's experimental because COVID-19 has made, until quite recently, its own new normal, as we keep hearing, and so the old routines of surgery just don't apply. It's surgery because we're studying a living response. We're seeking not just to study it like a vivisectionist, but to understand how the bones and muscles relate to one another so that we can improve the relationship between the two of them. For my team's part, this is the grant we put in and had funded. We've been studying how the muscles of policy move, or don't move, the bones of clinical action. We've been studying the policy implementation and communication lessons from our province's response to COVID-19. And we haven't just been studying in an anatomical sense. We've been intervening, feeding our findings back about how policy is or isn't being put into action right into the system. We've been intervening to support clearer communication and better implementation of policy. So who are we? The team of experimental surgeons looking to learn policy communication and implementation lessons from the pandemic. We're a mixed group, what you might call, if you were writing a grant, an interdisciplinary mixed methods platform. When you actually meet such an interdisciplinary mixed methods platform, it turns out we are experts in human factors, infection prevention and control, and organizational sociology. Human factors is a form of engineering that sits at the intersection of process and product design on the one side and human psychology and physiology on the other. It began its life as ergonomics and moved on from figuring out how best to sit and work at your keyboard to identifying physical or mental gaps that might be built into a particular work environment. It is the human factors folk who figured out how to make the infusion pumps less prone to operator error so that a patient would receive the dose that was required, not 10 or 100 times the dose by accident. Infection prevention control, IP&C, is an applied specialty within the worlds of infectious disease, epidemiology, and public health. IPC professionals are clinicians who know and understand the evidence around, on the one hand, a particular pathogen's transmission characteristics, and on the other, how life actually unfolds in healthcare. They are the rubber hits the road crew who work through the evidence and pragmatic needs to come up with guidance. Guidance on how other clinicians ought to be protecting themselves and cleaning their environments. And organizational sociology. It's a particular flavor of the bigger discipline that looks at the culture and context of organizations. It seeks to understand the ways people inside those organizations use culture. Let's say that might mean norms and values, and context. Let's say that might mean spaces and policies. How they use norms and values and spaces and policies to approach, think about, and react to their world. Organizational sociologists have been working in acute care quality improvement for years, offering views of how the culture and context of hospitals make the implementation or non-implementation of policy happen. Think of them as the small p politics folk who can figure out how policies are or aren't communicated and implemented. where the human factors folk are interested in individual psychology and how individual brains process situations. Organizational sociologists are interested in collective social processes that express and shape people's commonly held values. And what has this mixed group of experimental surgeons been doing since the 10th of March when we went into the field? Our live, real-time response to the pandemic has included observations, interviews, and feedback sessions to acute care and primary care teams. On the acute care side, this has meant we've been in emergency departments across the Calgary zone, as well as obstetric wards, ICUs, and even tent hospitals. This is the one that was constructed in the notch up at the Peter Lougheed Center. Now, we've also been collecting data on how communications from the AHS mothership and between the various departments do or don't happen. But today I'd like to focus on a particular research story that highlights our integrated knowledge translation approach. This is what you might call action research that we conducted on Ward 64 at the Foothills Medical Center. Under normal circumstances, Ward 64 is a surgical recovery unit. Their bread and butter is providing routinized care to patients who have scheduled hip and knee surgery. This means they are a bit outside the normal flow of the hospital. They do what they do with patients who are being brought in for surgery they already know that they're going to have, rather than patients who might show up urgently sick at the hospital. They were told over a period of hours that they would be switching from post-surgical care to medical respiratory care. That's the care that's at the heart of treating COVID-19. There were, as the nurse manager will explain in a second, some issues to overcome in this new, unfamiliar role.
Hi, Miles. This is Angie. Are you trying to play your video?
Yeah.
I don't think you were able to switch tabs. It's not appearing for me. Just want to make sure everyone gets a chance to see it.
Okay. So it says that I'm sharing this, but nobody can hear it? Nobody can see it? Is it showing up now, Angie?
Not for me. How about for the other panelists?
No, not over here either.
Oh, that's interesting.
I don't see it.
Oh, this worked in rehearsal.
Do you have multiple windows? Because you might need to switch the window that it's being viewed on.
Nope. It should just be a toggle back and forth in my meeting controls. Anybody seeing that now?
No.
Never mind. What we shall do is, in an attempt to keep things rolling, as I said, this worked in rehearsal, folks. This worked in rehearsal. It is not working now. So there was, if you can picture, somebody from this unit that you see in the background, and she spoke about how a bunch of people from Human Factors and Infection Prevention and Control came along and gave them a hand figuring out how to rework their shifts and redo their patient care. The good news is that we didn't just have to watch a video. We could also, hopefully everybody's back and now seeing my slides. We have a bunch of, think of this as the Home and Garden TV Property Brothers moment, before and after photos of some of the work that our team was able to do on the unit. So top photo here, leftovers from lunch, as you can see, are still available. They and the garbage bin are conveniently located right next to the cleaning equipment trolley. And then there's a cleaning cart that began its day. You can't actually read this on the side, but it says that it's come from the 10th floor and it's now become part of the action down on the 6th floor. In the bottom, the clean equipment is conveniently tucked away on a multi-purpose chair. That could be a chair, could be somewhere where you keep your new scrubs. And then there's also some stuff piled up on a desk that is also a patient's table to eat off of. That, if we go through the magical transformation, becomes something different. Now, after the Property Brothers, the experimental surgeons went through, not only is this more aesthetically pleasing, and that's clearly a debate that we could have, the image on the right at the top shows the application, or sorry, both of them show the application of IPNC and human factors principles to reduce both the chances of infection by keeping contaminated items with like material. So if you watch between the left and the right, dirty is red and physically separated from clean, which is blue, not they are on top of one another and then next to one another. The lunch is gone. The garbage is in the red zone and the blue zone is separated by a door space to keep things easy. The cart, which had begun its day up on 10 and was going to return to 10, having spent time on 6 where it could have picked up bugs, is no longer able to do that. It is confined to 10 alone. All of this, from a human factors perspective, reduces the chances that a human at the center of things could make a mistake. And from an IP&C perspective, reduces the chances of COVID being transmitted. Now, organizational sociology is not in the foreground in either of these. Rather, the sociologist is working in the background, drawing out culture and context, both to make the feedback more effective, because I think everybody can imagine that if you dropped news on people that they had to change the way they were doing things, and you do it in the wrong way to the wrong person, it probably doesn't touch down terribly well. But also as part of playing a longer game in which we can tell bigger stories about communication within and across wards during the pandemic. So think of the sociology as the movie version rather than the half-hour Property Brothers reality show where we go from before to after. And perhaps that's better to think of human factors and IP&C as being better at the experimental surgery work and organizational sociology being a little bit better at the long-term anatomy work. Over on the primary care side, we've been working with clinics in the Calgary zone to develop and deliver what is, to our knowledge, a novel transition support program. Now, that is, once again, a bit of grant writing rather than straight talking. I'm sorry. The parts that make up this transition support program aren't actually new. We scavenged them. More of an anatomy move than a surgical one, but there you go. You've definitely got some muscle and bone there, although when I look at the picture, it looks a bit like more bone than muscle. In any case, we've scavenged the parts from work in acute care quality improvement and preparedness. And these parts were to help primary care teams transition into caring for COVID-19 positive patients while keeping their regular practice also going. So if you define innovation as new ways of doing old things, we were in the innovation business, coming up with ways for primary care to deliver its usual services safely and efficiently. Some background first. Much of what has been published in the media, and indeed much of what has been implemented through public health powers, has focused on the acute care system. We are coming to the close of a curve flattening cycle that had as its central goal the protection of acute care resources and the prevention of a patient surge, a surge of COVID-19 patients with the power to swamp the system, as happened here in Italy. In all of this, acute care beds, protecting them, creating them, staffing for them, those beds were at the center of the news and the public health policy. If you heard about primary care in Alberta, it was likely as part of a story about PPE or billing codes. Extraordinarily, AHS was told by H that primary care would be supplied with PPE. This was extraordinary because most of the province's primary care doctors are independent fee-for-service contractors, not AHS employees. Extraordinarily, AH introduced telemedicine billing codes for family doctors to use as they offered virtual care to their patients. This was doubly extraordinary because billing codes, or at least one specific billing code, the complex care code, was and is at the heart of a huge battle between government and at least primary care, if not all doctors. So if you heard about primary care, you didn't hear much about the in-person services that family doctors might now, or will eventually in the future, need to deliver. In fact, we found through our interviews that many family medicine clinics had important, life and death kind of important questions about how they should redesign their workspaces and their workflows. I hope that you can hear something coming that has human factors, IP&C, and OS in it, just like we did in acute care. So our team scavenged parts to create a how-to program for primary care clinics. The parts we scavenged were tabletop simulations, Zoom, and Mural. I think you can figure out the Zoom and Mural parts. Zoom to talk to rural clinics at a time of physical distancing, and Mural to work with teams in those clinics on a floor plan in real time. But what is a tabletop simulation? In a tabletop simulation, a facilitator, in our case, human factors and IP&C experts, convene a session with a primary care team. They would do so using Zoom. In this session, our experts and their team would work through specific scenarios using a floor plan of their office. It's a sort of pressure test of sorts to identify any gaps or lapses that might be built into existing policies and protocols. A scenario might be a family of 3 arrives in your family medicine office. The father is presumptively COVID positive. How do you move them around the space? The group works through this. They would do that using Mural. Using the software where they would talk through options and alternatives, arriving at processes and spaces that are tweaked or in some cases completely redesigned. All this seems self-evident as I present it to you here, but we had to figure out and test all the parts of the delivery platform before we could even start trying to agree on scenarios and carry out the sims with the primary care teams. From an original prototype, we have now piloted and iterated this in 8 clinics. The reaction to this scavenger-based experimental surgery has been consistent. Some of the reactions recorded in follow-up surveys with a group of rural clinics. We've been providing customized feedback packages to each clinic and also drawing out higher level lessons, putting them into a key learnings document for all of primary care. Our organizational sociology team has been following up with in-depth interviews to better understand the flows of policy communication and implementation out of AHS and into primary care and then back again. For those who are interested, an integrated knowledge transfer page of emerging findings and on the interventions that we've conducted to date is available here. I'm happy to take further questions on that, but the broader point of this website that I'm pointing you towards here is that you can see, rather than the thumbnail sketch that I've just given, the actual evolution of the prototype into the pilot for the primary care material, and also a little bit more in depth on some of the other projects that we've been working on inside acute care. I will, because I think I've already overtaken my time, pass it along to my colleague Jennifer Zwicker, who is also, I'll try to do some sort of meshing here. We've just reapplied for scale-up money for the project that we started in primary care. And the point of the scale-up money is to say, we've got something that we've prototyped and piloted and is out there, and there's huge appetite for this. Now, the fact that primary care wants it, okay, that's maybe you could say nice in and of itself, but I think most people who are looking forward to a potential second surge as flu season combines with, we come out the far end of the curve flattening exercise. The next round of COVID-19 is going to be managed in community, and primary care is going to be a very important part of that. Also in community are the families and the children who need the extra help that my colleague Jennifer Zwicker is able to talk about. And so I give you Dr. Jennifer Zwicker.
Excellent, thanks, Myles. I just need to share my screen.
And I need to unshare mine, 2 seconds.
Seamless transition. And I need to go slideshow. Great. I think that everyone can see that. Okay. Hi. Thanks, Myles. That was a nice transition.
Jennifer, just sorry to interrupt. We are just on the presenter view if you would like to switch your display settings.
Oh, yes. Thank you. Swap displays.
Perfect.
Are you on the correct one now?
Yes.
Excellent. Thank you for that. Okay. Thanks, everyone, for working with us through our Zoom technicalities here. Yeah, like Myles said, I'm going to talk a little bit today about a specific population, particularly focused around supporting youth with disabilities and their caregivers during this COVID-19 pandemic. I've set that across a photo of our beautiful Rocky Mountains and the crocuses being out, and kind of thinking more optimistically and kind of future focused in terms of policy development. So I just wanted to highlight this quote from the UN saying, we must come to the aid of the ultra vulnerable, people who are least able to protect themselves. This is a matter of basic human solidarity. It's also crucial for combating the virus. And this is the moment to step up for the vulnerable. This is, really thinking about, Myles was talking about some of the systems that are rapidly evolving. And I guess the core message I want to get across here today is, as we're rolling out a lot of these policies and programs, we have to be thinking about the impact on some of these vulnerable populations, such as youth with disabilities and their families. So for those who haven't maybe been as familiar with disability, it's a wide spectrum of conditions resulting in limitations in functional capacity that impact activities of daily living. You can have physical limitations, we can have invisible disabilities, mental health conditions, and there's developmental disabilities, which are usually occurring from birth. So the context around disability policy in Canada is UN Convention of Rights of Persons with Disability, which we're a signatory to, really talking about the necessity of providing meaningful participation in society via aids, supports, and policy to facilitate full participation in society and reduce barriers. So policy has a really profound impact for this population. We know that it's really important to think about this from a life course perspective. There's a number of different ways that across the life course that policy can influence overall health and well-being. So thinking about things like family and parenting environments, positive school environments, access to healthcare, social services, education supports, income levels. These are all things that policy really impacts. So fundamentally, this is an important space. Now you layer on, we're in a pandemic with the COVID-19 policy that's being rolled out. And there's been some really profound impacts to some of the existing supports and services that are present. So as we think forward towards kind of a disability policy lens on kind of COVID-19, kind of new policies that are being rolled out, we need to be thinking about that context and the environment we're in. So the reality is, despite this kind of international and rights-based framework and that federal policy that exists, a lot of the actual supports and services that are rolled out happen provincially and locally. And unfortunately, we know that tends to be kind of a patchwork of services. This quote from the In Unison report really highlights that. But it's really grounded in the fact that we do have a lot of this federal legislation. We recently just passed the accessibility legislation, but how does that trickle down to the way provinces and municipalities are rolling out specific policies, particularly during a pandemic? So we know from the World Health Organization and from UNICEF that there are a number of important considerations for youth with disabilities and their families. So for example, higher risk of adverse outcomes from COVID-19. I'm going to go through each of these four categories a little bit more in the rest of the presentation. Challenges of implementing infection and control and acquisition of timely information. There's been significant disruption to the usual supports and services, and controversy around designation of what is an essential support and service in this context. And just thinking about what we know about low-income populations and the importance of spread across this population and how disproportionately represented persons with disability are in kind of low-income populations. So I'll shift to the first piece around higher risk of adverse outcomes from COVID-19. So we know that youth with disability have higher rates of comorbidity among among youth with disabilities. This would be chronic conditions and also mental health outcomes. So, it's not necessarily disability itself, it's more just the kind of health concerns that tend to be comorbid among persons with disabilities. And we also have seen information, as you've seen, around residential group settings and just concerns about needing to have support workers in there, and the higher risk factor of adverse outcomes. So in New York, there are reports around 5 times more likely to be infected with COVID-19 and about 4 times more higher mortality rates. So these are important considerations and concerns as we're thinking about the way we're rolling out policy. Second factor would be challenges implementing infection control and acquisition of timely information. So we know that functional limitations are an important thing to be thinking about as policy is being communicated. So persons with disabilities are experiencing intellectual delays or might have sensory deficits that could impede their understanding of implementation of infection control or acquisition of timely information. And it may mean that they're not able to adopt a lot of the preventative measures, or may not be able to access or kind of self-monitor in the same way. Also challenging sometimes to enforce some of the social distancing or do that in the context of needing home care, those kind of supports. We've seen concerns early on around barriers around communication of information and making sure there's adequate plain language summaries and adequate sign language and things to that effect. So making sure that's present so that people can get the information they need. And then also hospital triage policy and no visitor policies have been, big concerns for this population, and thinking about the way, access to important health equipment, ventilators, but also thinking about having somebody who's advocating on your behalf able to attend and be a part of the experience of if you're needing to go into hospital. So the last factor, or one of the other factors, is around the spread among lower socioeconomic groups. And we know we know that persons with disabilities are disproportionately represented among lower socioeconomic status groups. This is from the Canadian Survey of Disability. We've updated this and are just finalizing a paper with 2017 data, but the numbers are similar. Mean employment income for adults with disabilities about $16,000 a year. So it's this is for developmental disabilities. So this is of particular concern. We've done some analysis recently in conjunction with the BC government, who have linked data across ministries, which has been very helpful. And I'll show you some of that data and what you can do with it in this kind of context. But before we get there, I just wanted to highlight that as you're thinking about implementing some of these measures among persons with disabilities, a lot of it in the early stages of the pandemic, it was thinking about making sure you had enough of your medications, that you had access to adequate food and caregiving and assistive device supports that you need. And fundamentally, if you're on a fixed income, this is a huge challenge. This figure is just talking about kind of disproportionate needs in this case. And we did an analysis around kind of poverty measures and the market basket measure, and seeing whether it was an adequate measure to be fully capturing basic needs for a person's disability. Conclusion is, there's a need to recognize some of this additional expenditure just to facilitate activities of daily living. So in the context of COVID-19 pandemic, we have to be thinking about, do persons with disabilities have access to all that they need, and are they able to do things like get the adequate groceries and supplies so they don't have to keep going to grocery stores and pharmacies and things like that. So we did do some analysis with some linked administrative data and just looked at, for example, income assistance recipients in BC. And in our analysis, we were just looking at risk for flu and pneumonia hospitalization, and found that there was a much higher rate of relative risk of hospitalization from flu or pneumonia when you're comparing disability assistance users versus the typical population. And of particular note is that this is occurring in younger age groups. So ages 18 to 35 experienced an increased risk, so a 17 relative risk compared to those of the same age. So this is something that, I think the key point is we need to be thinking not just about implications in seniors, but also thinking about youth with disability and adults with disability in this kind of context. I would also just mention that, this kind of linked administrative data where we can be talking about service use in a particular program, in this case, disability assistance, and linking that to health data can give us some really powerful information on particularly around how you might deliver programs in the future. So for example, in COVID-19, we're seeing a lot of variable responses across provinces to how youth with disabilities who are on disability assistance might be able to access the Canada Emergency Benefit. So for example, in BC, there's some ability to use some of the Canada Emergency Benefit if you're on disability assistance, whereas in Alberta, a lot of there's kind of a different formula around whether the Canada Emergency Benefit we claw back, and it's different across every province. So there's real considerations around how some of the kind of federal programs are implemented, and then how it rolls out province by province. And we're now just starting to see some announcements about kind of individual province level efforts. So, monthly benefits around, the child disability benefit, things like that, to try to supplement. And that's happening very locally. So just being aware of, given the extra needs for this population, how a lot of the programs aren't necessarily reaching people who may be really in need. So the last piece I just wanted to touch on is around the disruptions of usual and essential supports. And in a normal context, kind of non-COVID-19 pandemic context, this is a map that a family member's drawn around the services and supports that they need to navigate in the community, as Myles was mentioning. I think the context for COVID-19 is that many of these supports aren't necessarily available right now. So obviously that puts a lot of extra onus on the caregivers who already were providing over 80% of support for typical activities of daily living. So this is a comment talking from a parent who is saying, probably echoing the way a lot of parents are feeling, thinking, I don't know how we'll handle additional weeks off, especially without regular activities. School provides only education, social training, and respite for us. My eldest is already responding explosively, and we're having to isolate his younger brothers for safety. So thinking about kind of those dynamics in the home, if there's behavioral issues or anything like that, can be particularly challenging for families. So the family experience accessing services and supports, we know that there's, we've done a survey of families across Canada, and we're just wrapping up that analysis. And we've been looking, we have 531 respondents, and overwhelmingly across provinces, there's either a lot of difficulty or some difficulty accessing services and supports. We've completed 84 qualitative interviews with representation across provinces in both French and English, and can see a lot of the facilitators and barriers that are emerging from these programs, which is very instructive around kind of the way that you might better design policy to kind of more navigate a lot of the fragmentation that occurs across provinces. So in the context of COVID, I think we're conscious of the critical aspects of how this rights-based framework starts to interface with provincial and local service delivery. And a stark example is the concerns people are raising around Article 25, the right to accessible health services, and thinking about how some of the policies might be playing out in hospital settings around the way persons with disabilities can access services. Same thing for adequate standard of living and the right to accessible education and the support for home and family. So, thinking about the way some of these policies are impacting core programs and design in the COVID-19 context. So moving forward, of course, this is a very reactive response to COVID-19, and we're aware of that. So I think there should be kind of more consideration for, as we think moving forward around the disability inclusive pandemic policy response. Fundamentally, there's a knowledge gap. There's a knowledge gap in Canada, and there's a knowledge gap internationally. We need better data collection, and we need better emergency preparedness planning and response for persons with disabilities. So bridging that gap, we're working on a project building on that qualitative interview study I was talking about, looking at engaging persons with disabilities and families to kind of get an understanding of how across different provinces, different policies are being rolled out, because we know there's a lot of local innovation that's happening. And thinking about developing kind of community-based solutions. So really co-designing solutions with community partners. There is a recently announced a COVID-19 disability advisory group federally, which we have some good connections to that we're working with. I think that the core piece to this is starting to integrate some of those kind of higher-arching UN frameworks. So this is the Sendai framework for disaster risk reduction, which, you know, we're starting to really think about how we might draw on some best practice policies internationally and across Canada and provinces using that framework, and starting to spread those to provinces so they can start to see, you know, what other groups are doing that's working well. This is, you know, recently, I think that the positive light that the Government of Canada has announced this COVID-19 Disability Advisory Group. And you can see how having this group in place allows for kind of an advisory level role, consultation as policies are rapidly rolled out at the federal level. And so I think, you know, a key early recommendation is wanting some of those groups provincially, so that there's that same capacity provincially as ideas are being rolled out at a provincial or perhaps even municipal level. So, you know, from a co-design perspective, those are some of the pieces that we're actively working on, and just want to acknowledge the awesome contributions of a lot of the team. And this is an older picture of the team, but thinking about the community partners and support from networks like Kids Brain Health Network and Child Bright, and the City Family Foundation. So without further ado, I will hand it off to our moderator and welcome any questions.
Thank you very much to both of our speakers for very interesting presentations. So we will start with some of the questions that have been provided to us. First of all, I did really notice that both of you are working provincially, but you seem to also be very well connected nationally. And so maybe I'll just start off with both of you and just ask a little bit about the policy work that we're doing here in Alberta, how that is informing what's going on at a national level. So maybe Myles and then Jennifer, you could just answer that question, and then we'll let some other more questions come in from our audience as well.
I won't deliver my best stuff with the mute on. So on our side, yeah, we have been working. We've been working essentially inside the province to try to help immediate recovery or response stuff. That said, the work that's been done has kicked up a fair amount of interest in BC. There's people in Ottawa talking, and we have had people from both Médecins Sans Frontières and the National Health Service. The NHS has a primary care system that I will not say is similar, but it's at least more similar than the one in the United States. How about that? And so being able to provide this kind of support to primary care in the NHS is something that they're interested in talking about. And the MSF folks are interested in trying to find low and middle income country versions of this, particularly because we can deliver it virtually, for trying to help people who are going to be continuing to deliver care out in the field. So that's, yes, there is more reach to this. For the moment, we're trying to get scaled beyond Calgary zone, although that's where the cases are concentrated for the moment.
Yeah, I mean, I would say that similar to what Myles said, there's, particularly in this scenario, there's a need for kind of more rapid information exchange between jurisdictions. I think everybody's learning as they go, and thinking of different things that are working well and strategies that are, in the case of vulnerable populations, still aligned with kind of the needs of that population, but kind of emergency response perspective are important. And at this point, I would say the concern from the disability community has been that hasn't been on people's minds as much. And so, I think it's critical so that there's, as policy is developed in an ongoing basis, there are people that are there to consult, and families are a part of that. And because I think there's more harm that can be done when a policy isn't considering implications for some of these really vulnerable populations.
Okay, so I'm now going to go to our questions that have been submitted from our viewers. The first question is for Jennifer. It says here, local grocery stores, pharmacies, etc., are providing special access hours for elderly or those with physical disabilities, but this doesn't include those with COVID-19 physical vulnerabilities. For example, people with lung diseases, hypertension, diabetes, who aren't elderly. What are your thoughts on this topic?
Yeah, no, it's a good point. I think it's kind of hopefully a key take home from this presentation is we've had a big emphasis on seniors, which we should, but we know that there's another high risk group among youth with disabilities, and this is something that you don't necessarily need the same policy strategies in place, but there needs to be that kind of consideration, and we don't want to forget about that group, I would say, and I would suggest that many of those kind of accommodations in grocery stores and things like that are probably a good option for also adults who are younger that might have a disability and need a bit of extra time and space.
For sure. There's an awful lot of cross-fertilization in some of these policies. So the next question I'll just go to for Myles. This is from Penny Haw. She's asking, there can't be many ethnographers who study policy implementation and scale up. What kind of things do you feel you might be in a unique position to see or notice? Can you give us examples from the current COVID work? Just unmute yourself.
Unmute myself, thank you. Yeah, thanks for the question. There's just not a lot of ethnographers, period, let alone ones that have the playground that we are in at the moment. This has been spectacular. The original pitch on the grant that I put me and all of the cast of thousands that actually managed to do this. So Jennifer did a much better job than I did of saying, hey, and here's the whole team. I just kind of put one slide in at the beginning and hoped you recognized that I used we, and most of this is not me anyways. This ethnographer and a couple of other ethnographers are watching stuff happen, and our big question along this, so there's been work done in the past to try to figure out how it is that organizations do or do not change. Organizational sociology, Powell and DiMaggio won't get any more theory-headed than that, but they talk about ways that organizations look at one another and then sort of mimic one another or want to be like somebody else, so they adopt a whole way of thinking or department or something like that. Those are under normal conditions. What we saw, so we went into the field on the 10th of March, is for at least the first 2.5 to 3 weeks, all the rules were off. Nobody had any idea what was going on. Policy was coming down from the mothership, but it was this high level stuff like, don't put more than 25 of you in a room. Don't put any of you in a room. And then everybody sat there sort of trying to think, well, how do you operationalize that? I don't know what to do with that. So what I would call policy entrepreneurs started coming up with all sorts of local solutions, right? Oh, hey, let's do this, and let's have a protocol for that, and let's build that. So we have been watching in real time the sort of initial break flow of ideas and how are we going to do this and what are we going to change. That's now being sort of ebbed back with AHS saying, no, try like this has to be done like this. I want everybody on the same page about that. But there's been a moment as an organizational ethnographer where we saw brand new stuff being created, which is incredibly unusual, right? Like it's very, very rare that you actually get to see an organization do anything but sort of ponderously go through a big process, to have a whole bunch of meetings, to then think through and have a task force and whatever. And then eventually they kind of do basically what the other guy was doing in the first place. This has been just absolute Wild Westism in the best possible way because people are trying to get the best thing done. Like I won't go into the specifics because that's just the general story to be taken from it. But as an ethnographer on the ground, watching how it is that people are thinking about where they're getting their information from, where they say they're getting their information from as opposed to where they're actually getting it from, the decisions that they're making, how they're restructuring their lines of work, coming up with ways to undo their own mission, right? Like your mission is to support elderly people in the community and prevent them from being isolated. And now you have a new priority, which is to isolate elderly people in the community. This is how are they dealing with the cognitive dissonance of that and that kind of stuff. So we've had fantastic opportunities. You didn't hear much about them today because that's the long-tailed, as I was trying to make the point, anatomy question, as opposed to the short-tailed experimental surgery where we can get in, we can help, and we can make stuff happen.
Just unmute myself now. Thank you very much. That's a really great answer. So the next question is for Jennifer. What is the key variable in assisting and supporting families who have a disability person? Is it funding or is it coordination?
Yeah, so different provinces take different approaches to funding or services and coordination of services, certainly. I would take a step back though and say, first of all, it's commitment to values and kind of rights frameworks. And we see this playing out across different countries. So in the US, for example, there's been a lot of concerns around US's commitment to kind of ensuring the support for persons with disabilities. In Canada, I think we've been a lot better, which is great. And I think after that, you've made that commitment, then it's thinking about how services are, the response has been often kind of a health services focused response. And, you know, I think if anything we're seeing from this COVID-19 pandemic is there's a whole need to be thinking about how services are delivered in school, how we're delivering, how we're acting in schools, how we're interacting in the community, how do businesses roll out, you know, kind of infection control protocols and all of that kind of stuff. In the same way as people with disabilities have to interact in those environments as well, and kind of thinking about accessibility and those kinds of considerations. So, you know, I think in some ways, you hear from the disability community, some people are saying, well, and one shining light is that, you know, the work from home and kind of more accessible workplaces has been, you know, almost a way to kind of open some of these things up and kind of recognize different approaches. But I would say there's a need to be thinking beyond just healthcare services in hospitals, and the role of kind of public health and accessibility of community in a way that's different than we've been doing. And I think there's some parallels between the COVID-19 pandemic and what everybody's experiencing and the challenges persons with disabilities and their families have been experiencing before and now around the way they're accessing services.
That's a very good answer. I'm wondering if Dr. Leslie has anything that he'd like to add in response to what was just discussed here, because it seems to me that there are some parallels, wondering about, you know, how best to deliver healthcare within communities as well, and kind of lessons that we've learned from the COVID-19 experience right now, things that are positive that we can take forward.
Yeah, and I'll flip back to the previous question about what kind of ethnography are you doing? We're trying to figure out how much of this exceptionalism of the moment is an opportunity to anchor stuff that could survive, or if it all just goes back to the way it was. And clearly it's not going to go back to the way it was, because we've done a whole bunch of stuff to our economy, to a bunch of other things. So things are going to change. We're already on the change. But how much of this can be effectively leveraged to try to do better work in the community? I would agree completely with where Jennifer's headed on this, that, as I said as part of the introduction, we're the next wave, whether it's an actual surge that happens in the fall on top of flu season, or it's simply the consequences that were inherent when we were originally sold and bought the idea of flattened curves, that everybody has to work their way through the curve in the absence of a vaccine. This is going to be a community-based response. It has to be. We can't shut everything down like we did before. We can't go entirely on hospital like we did before. And that I shouldn't say it like that, but like we did before. The best possible things were done and the best possible plans were put into place to keep that acute care system open and ready to take what looked like was the tsunami that was coming at us, like it did in Italy. This has not materialized because of, we're not entirely sure, because it's a novel coronavirus, so nobody knows what's causing any of this. They've got hunches and clues, but the data they just don't make sense as you travel from jurisdiction to jurisdiction. the idea that this could be a window into the experience of people who have been living quasi-lockdown conditions for a very long time, have been putting up with and trying to understand and navigate through systems that are in the process of changing in ways that they don't understand and aren't necessarily particularly friendly to them. That would be a great lesson just in sort of general humbleness for all of us to be able to take away. And I'm always a bit leery of that, sort of grade 12 exercise of give the kid who's not great with other human beings an egg and tell that person to walk around for 2 weeks with it, and then when the egg breaks, they have the sense of, oh, this is what it is like to be responsible. I think there's sort of a falseness to that. But this has been 8 weeks that we've all lived, 9, 10 weeks that we've all lived, and had a sense of where what Jennifer calls the disability community has been. And beyond having empathy for that, it's understanding that the policy solutions that are needed to hit big moral commitments like the one she led with, but bring us more just in line with being able to provide basic services to people, this is an important, hopefully, tipping point.
I think this is a very unique time that we're in, actually, because the generation of new knowledge is very, very rapid, and the exchange of knowledge has been exceedingly rapid as well, as we see very quick publications, preprints of research that is happening. And it's also an opportunity for us to be learning from other jurisdictions within Canada, but also from overseas. And it's been quite interesting as part of the University of Calgary's COVID-19 task force that we've been doing quite a lot of that, looking at all the population-based control measures that have been put in place, what it seems to be working to control the pandemic, but also trying to think about what are the economic impacts, what are the social impacts, what are the quality of life impacts, how can we learn from what's working and not working in other jurisdictions. And one of the things that we have in Canada, of course, is that we are somewhat lagging behind other countries where COVID-19 hit earlier than we have. And so there has been that opportunity to try to learn. And I suppose in some respects, you can say we over-prepared within the healthcare system to flatten the curve because we were expecting, a higher peak. That didn't happen. But it also means that we learned from some of the other population-based control measures what would be successful, and we were able to implement them. But it's also been interesting to see on a policy perspective how the federal government has responded to this pandemic and what seems to be working. But there's going to be an awful lot of work to think about, which of these policies were actually effective and at a population level, but then also down to all the different population groups that are particularly vulnerable, which we've highlighted quite well today. Do either of you have any other closing remarks based on things that you've been thinking about or that you would like to add, since we have a little bit of time before we'll be finishing off pretty soon here?
I would just build on your comment about learnings, and I think one of the big learnings, like we were just talking about, is kind of the caregiver workforce, that it's this unpaid, kind of unrecognized workforce that now is really coming to the forefront. And as we're thinking about essential service designations and those kinds of things, absolutely we responded dynamically and quickly in the acute care hospitals and healthcare services sector. But I think this is where we have to really start thinking differently about the role of caregiving and support roles like that are maybe not our typical things that we think about. So I think that's a key learning going forward.
That's absolutely on target for sure. Myles, do you have anything you want to add?
I'll just vamp off of that to say that we watched a lot of, I call it policy entrepreneurship, because it's how do you implement this stuff. And now on the upswing of the curve, or hopefully not the upswing of the curve, but the retreat from all of the measures being put in, we're seeing somehow, I think, less attention to, and maybe that's because it's difficult to find a focal point against which you say, well, that's the thing that we have to protect. We're going to protect the acute care system. We're going to do this by flattening the curve. These measures will cause this to happen. We know that. Now we're going to take this measure away and we're going to take that measure away. When you don't have informal caregivers, which is not a great phrase for it, family caregivers, at the heart of how you're thinking about this, and you don't understand that that is $65 billion worth of labor, unpaid every year, that's contributing to, not contributing to, that is carrying the bulk of the load on most of the elder care that's done, all of the families that you heard about through Jennifer's presentation. This is leading to what I think for those of us at the high end of the spectrum is just irritating. But people are like, oh, now it's time to go back to work. You have to go back to work. And if you happen to work for an old-fashioned kind of company that says, no, 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 you're coming in now because that's over. You're not working from home anymore. The schools aren't open. And more niche to Jennifer's point, where are the services for these disabled kids? Where is this? Yeah, but the work's open. See, we're back on. We're thinking about the economy. And because we've lost that focal point where we could say, we're going to shut stuff down to protect the acute care system, and it's going to work like this. Now it's the economy sort of broadly conceived is the thing to do. And where's the ordering for this? Where, if you think through the fact that there is parental labor going into educating children, to taking care of the disabled, to how are you thinking about this rollout? And I don't think it's there for the moment. And that needs to be part of the conversation, not in an academic-y couple of months from now kind of thing, but now.
Well, that is a great thing to end on. We'll have lots and lots of future discussions, I'm sure, on this topic. So I want to thank both of our speakers for very stimulating and interesting presentations and for taking the time to talk to us today. And I also want to thank all of our audience. We did have one question that came in very, very late, so we'll answer that after this seminar. So thank you very much for your contributions today.
Great. Thanks for the opportunity. Thanks for coming.
Thank you. Goodbye.